Ji, Assalamu alaikum, everybody. Thank you very much for, again, tuning in and attending this webinar. This is number 6 in our series of daily webinar on COVID-19 sharing. Basically, we call a speaker to speak about whatever they want to discuss. But really, the purpose and focus of this resource and webinar is more interactive, more collaborative between the clinicians of Pakistan and United States and England. So England, the time is odd and not many people can join, but we have extended our invitation to all the UK physicians, and one Dr. Hafiz usually comes in most of our webinars. So with that, so this is our format, that we have some panelists, we have most attendees. Attendees can raise their hand and we can address their questions or concern, but the most appropriate is to write your questions in chat box or Q&A, because sometimes one of the panelists or one of the attendees can also answer it right there in the chat box or Q&A. But of course, we would like to reach each and every question, and panelists will discuss that as well as the speaker. So with that, I would invite our today's speaker, Dr. Sajid Mehmood, to please introduce himself by telling us where is he working and his background and current experience. I know he currently recently had very hectic weekend and very big experience with COVID-19 patients. So Dr. Sajid, please introduce yourself. Then I'll ask the panelists to introduce themselves, and then Dr. Sajid, you will start your presentation.
Assalamu alaikum, everyone. Thank you, Shahid and Danish and APPNA MERIT for having me this opportunity to share my experience with all of you. My name is Sajid Mehmood, and I'm a Dow Medical College graduate of 1990 and currently practicing as critical care physician since 2002. I am currently affiliated as a consultant intensivist with OSF and Memorial Healthcare, as well as I contribute my time as electronic ICU physician, because under current circumstances, the role and importance of telemedicine, especially electronic ICU, cannot be underestimated. I had enormous experience on both sides of the camera. Sometime when I'm in the hospital, so I get help from my colleagues sitting behind the camera and contributing their efforts and assisting us, while when I'm on the other side of the camera and I can help my physicians who are physician colleagues who are present in the hospital. So saying that, the topic today that I want to address is to have an overview and then recent updates, because this is an ever-growing topic, and we learn something new every day from our colleagues and from those who had experience. Thank you very much.
Yeah, good. Dr. Sajid, we will come back to that. I would quickly ask our panelists to introduce themselves. I would first ask Afra Reis to please introduce yourself.
Dr. Reis is in attendees, Dr. Sajid.
Oh, I'm sorry. Let me, yeah, I was in the wrong panel. Okay, so here I see Mahmood Alam. Dr. Alam, please introduce yourself.
Thank you. Assalamu alaikum, good evening. I'm a cardiovascular specialist with special advanced training in interventional cardiology. I'm in New Jersey, and I'm the medical director of Hackensack Meridian Raritan Bay Medical Center. I also chair the critical care committee, and in the same institution, I also played a role of director of critical care for 7 years. So I'm here to contribute something which could be helpful for all of us to deal with this disease and help our patients and help ourselves to protect ourselves while delivering the best possible care to our patients. Thank you.
Thank you, Dr. Alam. Fawad Chaudry, you're next. Please introduce yourself.
Assalamualaikum. I'm pulmonology, critical care and sleep at University of Oklahoma, or I'm director of interventional pulmonology there as well. Batch 2002 from RMC. So just contributing to, experiences with COVID as everybody else. Thank you.
Thank you. Dr. Majid Shafiq, please introduce yourself.
Yes, Assalamu alaikum. I am a pulmonary and critical care physician, so an intensivist, and also director of interventional pulmonology at Brigham and Women's Hospital in Boston.
Thank you all. So with that, we will start. We'll ask Dr. Sajid to start, and then we'll open up the question answer, and we will get to attendees also. So basically, this is just to keep the structure. The attendees are as important and as honorable and as important for us, because it's really all the clinicians who have come. It's just our way that we make some 3 or 4 panelists, and we want to bring more structure to it, so that all panelists keep on changing every day or every other day. So we will request tomorrow, I'm going to reach out to most of you who have been regular attendees with us, to please give us your dates when you're available, so that we would like all of the attendees to take their turn to be a panelist in our program. So Dr. Sajid, please go ahead.
Okay. So as Dr. Shahid Rafiq mentioned, that today's session would be more interactive nature, so that we can ask questions from each other and benefit from each other experience. So I'm going to just overview quickly that what we already know and what we are doing. So COVID-19, as the name suggests, coronavirus disease that started in Wuhan city of China, and the 19 suggests the approximate time frame around November of 2019. And the specific terminology, as we know, that this virus is called SARS-CoV-2 to differentiate it from the earlier infection from a couple of years ago. The risk factors, even though it's not clear-cut, but those who had been known to be exposed are those people more than 60 years of age, immunocompromised people, residents of long-term facilities, as well as those with cardiology, underlying cardiac comorbidity or pulmonary problems, as well as liver disease. As far as symptoms are concerned, it has been seen that most of the people who presented with suggestive symptoms, they have mainly heart rate more than 120 beats per minute, respiratory rate of more than 24 breaths per minute, as well as oxygen saturation less than 90 on room air. Common symptoms, basically, in the triage area, they presented with fever, cough, and shortness of breath. Yet, the main feature which differentiates this from other respiratory problems is silent hypoxemia, that they don't look clinically as sick as the underlying hypoxemia is. And I am witness to that personally. A patient, my first patient that I intubated almost 3 weeks ago, and 30 minutes before I intubated him, he was sitting in his bed, and I had a full conversation with him. he spoke to me without getting even short of breath, and he was able to speak in complete sentences, yet his chest x-ray was looking horrible, and he was requiring up to 60 liters per minute oxygen per high flow nasal cannula, and still we were unable to get. So that terminology is also mentioned in most of the literature as silent hypoxemia. So that's something that we need to look for. Lab abnormalities, as we all know that lymphopenia, high C-reactive protein, elevated ferritin, and elevated D-dimers, those are the common one. And even though serum procalcitonin was noted to be slightly elevated, it was not that strongly associated with the severity of disease. Most of the places they are doing RT, CRP, C-reactive, PCR, polymerase chain reaction for on nasal swab specimen, and that's people are not going for respiratory cultures and everything because that is considered to be significantly sensitive. Chest X-ray and CT findings are typically suggestive of patchy ground glass abnormalities. Those patients who end up in intensive care unit and require some sort of ventilator or prone ventilation, they have a condition called cytokine storm, which is considered to be mainly responsible for ARDS like picture. It's not typical ARDS, but ARDS like because some of the features differ from typical ARDS, and one of them is alveolar flooding. That's why prone positioning is of high benefit in these patients, because that improves more effective drainage of alveoli and airways. As far as specific treatment is concerned, even though the literature is not that strongly in favor of hydroxychloroquine, yet it is being used in almost all sick patients, and in my discussion with infectious disease people, that maybe just because we have deficient data doesn't exclude this as an important tool in treatment. The main reason and the mechanism of action that it is active, the hydroxychloroquine is active against interleukin 6 and 1. That's why it is helpful in these patients. Initial antimicrobial choice should be rocephin and azithromycin. And talking about azithromycin, when you combine it with hydroxychloroquine, then QT prolongation should be a stronger consideration. That's why we usually get daily EKG and measure, and we have set up a cutoff limit of 500 microsecond for QT prolongation. And once we achieve that, we try to drop one of these if we can. Specific antiviral agents. In the initial treatment, we start using Kaletra, but the favor and its benefit stop going down after 1 week. And as of now, most of our patients are being treated by our infectious disease colleagues with Prescobix, which is combination of darunavir and Cobistat. So, with our experience, and as of now, since this thing started in Chicago and especially Cook County hospitals, I had experience of treating over 100 patients, and so far it seems to be. I mean, of course, we cannot say for sure that that's the only agent causing benefit, because of course you are using other modalities also, but so far this agent is being helpful. As far as cytokine storm, we talked about interleukin 6 inhibitor, tocilizumab, is being used, and just yesterday we started this medication on 3 of our patients, and the benefit is yet to be seen. But the main indication or the burning question here is that who should be the right persons to be treated with interleukin-6 inhibitor. So I have reviewed literature, especially Italian and Chinese, and the thing which I found common in having the identification or like selection criteria should be that there should be, if you are experiencing progressive increase in C-reactive protein, interleukin-6 levels, and ferritin, then you should think about using tocilizumab. Besides, if shock is worsening and vasopressor requirement is going up and ARDS is getting worse with worsening PO2 FiO2 ratio, that should be enough consideration to consider interleukin-6 inhibitor. So with that, I will leave the forum to our distinguished participants and other panelists to ask questions and share your experiences. Thank you again.
Thank you, Dr. Sajid. That was a very nice, brief overview, and we all needed that. I would say that let me ask panelists for just a quick round of comments, and then we go to the questions. So Fawad, do you have any comments or new point that you would like to share?
So it was a very good summarized version, or I think one of the very important points जो आपने tocilizumab का बताया कि inflammatory markers are very important जब आपका या तो multi organ failure हो रहा है या severe ARDS हो रहा है. अच्छा, उसके अंदर जो एक मसला आता है बहुत से centers में कि interleukin-6 का level which is 400 for this is not available in majority of the centers unless you are in a very big center, and I'm not sure Pakistan में उसका क्या सिलसिला है. तो उसके लिए as Sajid bhai mentioned, ferritin and CRP, or अगर CRP is going close to 10 and ferritin is going close to 1000, that is the time, or they're trending upward, that is the time that interleukin-6 blockage should be tried. और again इसका response mix है, chest X-ray infiltrates बहुत अच्छे जल्दी improve हो जाते हैं, but there is some immunosuppression evidence as well. फिर इसके अलावा एक और बात मैंने again I think when I go on my own Sunday, there is some conflicting evidence of steroids. SCCM suggest कर रहा है severe ARDS के अंदर, और WHO और CDC नहीं. इसके अंदर I will bring out a recent paper that is going to be published. There is some evidence of trying steroids with a very severe ARDS, क्योंकि वो भी immunosuppressant है और tocilizumab भी immunosuppressant है, so both of them are, but toci is much more suppressive. But in any event, I think for now we can keep it on the side, and then I hopefully that paper will be published by that time, so I will give that reference as well. तो ये दो important points है, बाकी I think summarized बहुत अच्छा आपने किया है, so I'll just leave it to the rest of the panelists and Q&As afterwards.
Shahid, if you allow me, can I add something?
Yes, Sajid, बिल्कुल.
The thing which I think I missed, I want to talk about that it has been brought by my colleagues recently that this disease is presenting with a bimodal pattern. That the initial we have seen that there is initial recovery in our patients, and we transferred them after 5th or 6th day out of ICU, thinking that they are improving, but yet they deteriorate on medical floor, and significant number of them got readmitted to ICU with or without mechanical ventilation. So we have to find out what's the exact explanation, but the most likely thing which is coming to my mind and in my experience, that probably this cytokine storm is not, in some patients it's occurring earlier that we are able to appreciate in their initial stay in ICU, but in some patients it's not manifesting itself up to day number 10. And that's where, you know, these patients are having illness after initial recovery. And one more thing I want to add, that mechanical ventilation with and without proning, we have compared, and I think those people who were put on prone position sooner than later, they are being helpful. And I think the underlying mechanism and rationale for that is that prone positioning provide improved and effective drainage of alveoli and airways. That's why. And we have started awake ventilation also, where we ask our patients to just lay on their belly, and if they are cooperative enough, we can just talk to them and they can do on their own. But if they are restless or agitated, or so then we use some slight sedation to accomplish that. So this is something, and I guess Dr. Fawad mentioned that, you know, we have to come up with interventions that can be done in Pakistan, and I think in some of the institute. Talking about interleukin-6 levels, you are absolutely right that even in United States, not all the hospitals have this facility. Luckily, our center has it, and we have noticed levels from 7 to 111 in various patients, and they are in varying degrees of illness. The normal level in our center is up to 1.8. 0 to 1.8 is considered normal, and anything above is considered elevated. So I have yet to learn, and I'm searching the literature that which level should be enough to consider tocilizumab for that. And of course, until then, we are looking at other features also. And if all these things fail, then of course, extracorporeal membrane oxygenation with VV version is a consideration. But my experience in that regard is limited, because not many of our patients got to that point where VV ECMO was used on them. Thank you.
Thank you. So before I go to Dr. Alam and Majid, I wanted to interject, and you can, you know, whenever you're talking, you can address any of the panelists and speaker, that this has been observation and a surprise for a lot of clinicians when we hear, for example, there's a prominent surgeon in UK, Pakistani surgeon, who went to, I was told, went to the hospital with symptoms and was sent home. And then he went again after 2-3 days when he was getting worse, and then again was sent home. And then after a few days or a couple of days when he was getting worse, and so people told him that you are a surgeon in that hospital, why don't you ask them that, no, you need further admission. So now, unfortunately, he's in ICU and probably intubated. So I think that's the IL storm that you're talking, but how to tell when is that storm going to hit so that people don't take it easy, or is it maybe rationing and they want to keep the ICU bed and others for other hospital bed also for really severe patient, but at the same time these patients can decompensate very quickly. So that's a dilemma I think many clinicians are facing, when to really take it seriously. So I will go to Dr. Alam for his comments. Dr. Mehmood Alam.
Okay, thank you, Shahid. So I think that this tonight's talk is revolving mostly on the experience and different modalities being used in the intensive care settings. And Sajid Mehmood has put things very well together. In fact, I increased my knowledge as well tonight. While we are still trying to define the natural history of the acutely ill patient with this disease, it has come to the attention to me as cardiologist that the case fatality rate average in cardiac patients is 10.5%, although the general case fatality rate is 2 to 3%. And some countries have reported even less than 1%, but I think now it is increasingly being recognized that it is higher than that. So cardiac patients, whether they have the disease or they have a naive cardiac, they never had any cardiac problem, but substrate was there, so mortality is very high. There is a recent article published in JAMA from Wuhan experience, 138 hospitalized patients with COVID-19. So 16.7% of the patients developed arrhythmias, okay, and 7.2% patients who were admitted in the hospital had a cardiac injury as evidenced by high sensitivity troponins. In those who were critically ill and were intubated and had a severe respiratory failure, ARDS, 1/4 had the evidence, biomarker evidence of myocardial injury. So in these critical situations, we cardiologists divide the myocardial injury into two types. Type 1 is a classical plaque rupture and occlusion of one of the arteries giving acute myocardial infarction, most of the time ST elevation, which is very clearly evident whether the patient has a COVID or not. And second is the type 2 myocardial infarction, in which patient usually presents with something else. And intensivists tell you more than we can tell as cardiologists, that they are usually the patient who has sepsis, they are in shock, we don't know what's happening, and their troponins are elevated. And those people have substrate, and most importantly, those people who have high troponins without obvious myocardial infarction has the high mortality. So same thing is true with patients who have COVID-19 and they are being managed by the intensive care physicians in the hospital. So arrhythmias are also common. About 7 to 8% of the patients who are admitted, they will have arrhythmias. Some medications or combination of the medications can give, as mentioned earlier, chloroquine and azithromycin, acute prolongation, which in a small percent of patients can be fatal, leading to torsade de Pont kind of ventricular tachycardia and sudden death, and it has been reported in these cases. Whether that sudden death happens due to severe myocardial inflammation directly by the virus or due to arrhythmia, it is still being debated, and things will be known after we experience all these things. Last thing which I will mention is, as a bridge, when we work with our critical care colleagues and cardiology support comes in, I think ECMO still has a role in very critically ill patients, especially who are relatively younger and losing their life due to just a mere severe hypoxia, which cannot be improved by any modality which has been mentioned before. And V2V, veno-venous ECMO treatment, it is not available in every center, but in New Jersey, regionally, these things are available. Expert teams are available. They go to that hospital. If you identify the patient at the right time, you can ask them to come. The whole team comes and they put the patient not only on ECMO, but patient is transferred to the tertiary care center where outcome can be improved. And we are still learning how we can improve the outcome of these patients. So these are my comments. Thank you.
Thank you, Dr. Alam. So now, before I go to our panelist, Dr. Majid Shafiq, I would start taking questions because I think the list is getting longer. And we also have some questions on our WhatsApp, which we specifically developed so that people from Pakistan and others can post questions there. So the first question, I'll come to attendees who are raising hand in a minute. Let me first take in order of the questions as they came. It is an interesting question from Nurunisa Pasha that what do you think, Majid, first you, that why our president is pushing for hydroxychloroquine?
Gee, thank you very much. I think obviously there's a great appetite for something that can be done to alter the natural history of this disease. To date, we don't know there's anything we can do. Dr. Shahid laid out a perfectly good example, right, of the surgeon in the UK. And then before that, Dr. Sajid in his excellent talk mentioned, that the story of the patient who seemed to be doing pretty well just before he wasn't. And the frustration is that at this time, there really doesn't appear to be anything tangible, perhaps other than hydroxychloroquine actually, that can be used to alter the natural history of this disease. This is the only thing that we do know thus far. It seems to affect lysosomal pH intracellularly, and perhaps it can inhibit viral entry into cells, or right after viral entry, it can perhaps inhibit viral replication, progression within the host, within the human being. So I think we're all somewhat, guilty of that optimism because it comes out of some desperation. So that's where hydroxychloroquine is, becomes a favorable and attractive modality. Currently, there is a trial going on in the US that looks at specifically, high-risk healthcare workers, so people who are working in the ICU or emergency department, etc. And so therefore, they're very likely to contract COVID-19, but they haven't yet. And the trial is looking at placebo versus hydroxychloroquine for several weeks, up to 12 weeks. So that is really the way to know for sure whether or not hydroxychloroquine can help with prevention, but so far we don't.
That's for prophylaxis or treatment?
It's for prophylaxis.
Prophylaxis, yeah.
Gee.
Okay. All right. So the other question
Shahid,
is...
sorry, let me add a little bit over here also. So talking about hydroxychloroquine, I mean, it's not about president, but the thing is that it is, I mean, theoretically and by as far as mechanism of action is concerned, as I mentioned in my earlier description, that it does affect, interleukin, and then as Majid mentioned about lysosomal activity. So, and because the literature is overall lacking in the ideal treatment of this disease, so we have to use everything, and the combination might work for the treatment. So that's why we are combining this with appropriate mechanical ventilation or non-invasive oxygen delivery, like high flow oxygen cannula, awake proning or proning with mechanical ventilation, interleukin 6 inhibitor, antiviral agents. So that's where hydroxychloroquine comes in action. And even though you talk about prophylaxis, but it is being used as part of regimen for active patients also. And in my center, which is treating, I mean, as of today, they have 100+ patients, including ICU and floor, and both major infectious disease services, they agreed that it should be part of initial treatment. Those who have confirmed COVID-19 infection or unconfirmed with significant clinical effects. That's one thing. And another thing I want to add, that with our limited experience, we came to know that another phenomena, which is microthrombi as well as macrothrombi formation, is also contributing to the severity of illness. So we have to have our index of suspicion very high. And that's the rationale to get initial D-dimer as well as follow-up D-dimer. And if you see, I just did some search today and found out that some of the investigators, they are using more than 1 gram per liter D-dimer elevation is strongly associated with in-hospital death. So please take that. And a cohort study said, revealed that non-survivors, that they compared 2 groups, the survivors and non-survivors from COVID-19, and non-survivors have significantly high D-dimers as well as fibrin degradation products. And 70% of non-survivors had clinically suggestive disseminated intravascular coagulation. So please keep your index of suspicion high. Until last week, I was not paying attention that much, but now I check each and every patient for that. And if necessary, you get, Doppler venous exam of that. And if, unfortunately, we have limitation for getting CT, pulmonary angiogram of chest, because of, contamination and isolation limitations. But the thing is that if your index of suspicion is high, start them early on anticoagulation. And talking about anticoagulation, it has been seen that Xarelto and Lovenox are superior to unfractionated heparin or oral anticoagulants. Thank you.
So that's great. Actually, you answered this question from Farhan Qadeer and about the heparin use in microthrombi and all that. But another question is that there is obviously a panel to order like CRP, ALT, and others, lab derangements or lymphopenia. The question actually is to when should they be ordered? Because so the real question, as I understand, is that what is the lag between the clinical symptoms, initial mild clinical symptoms, and these labs to become positive? And so that way, when should they be ordered from the mild symptoms?
Is that question to me, Shahid?
Yeah, you can tell, then we can ask the panelists as well.
Yeah, so let me say that as we, myself and other colleagues also mentioned, that we should not focus on just one thing. It's a combination of everything. So it's my personal experience that I'm more involved in those patients who are sick enough from emergency room to end up in ICU. I didn't see too many on medical floors. Of course, I am assuming those are relatively stable. And if those has not made up to ICU, so they have recovered and left hospital. But those who are ending up in ICU, almost 90% of them have lymphopenia. Okay, so this is something that is considered. And after lymphopenia, the feature which is most common, which is present in all of them, is ferritin. I'm surprised to see that how ferritin is so strongly associated with the severity of illness in these patients. So lymphopenia, ferritin level, CRP, because CRP is more sensitive than procalcitonin in these patients. So these are the one which, of course, colleagues in Pakistan can also benefit, because these can be ordered over there also, compared to more sophisticated tests like interleukin-6 inhibitor. So answering to your question, that combine it with other symptoms and other lab tests, and then go for your decision.
Good. So any other panelists have a comment on this before I go to attendees who have raised hands?
I can add, excellent list that Dr. Sajid mentioned. Typically, I have seen that the transaminases, so AST and ALT, tend to go up fairly early on as well. But I will say with the caveat that we're still learning a lot about the disease. So these are still, you know, our impressions could change. I think at this time, if you're trying to figure out whom to test, anyone who has a fever, anyone who has anything that looks remotely like a viral URI, anyone who has any new onset cardiac symptoms, those are certainly the kinds of people that I would want to test. And yes, then if you're still looking to find additional sort of clues, then all the labs that Dr. Sajid mentioned. I will also quickly add, you know, we were talking about hydroxychloroquine. So in our center, we are also similarly using hydroxychloroquine as a treatment modality as well. Typically, if a patient is sick enough to require supplemental oxygen and is not eligible to be in any formal trial, then as a last resort, again, because, you know, the data is sparse, but that's the data that we have so far, right? And so that's what we're going for, because short of that, we don't really know what else we can do to help these people.
Okay, great.
Okay, so I can quickly add just one quick comment as Majid and Sajid mentioned. So in our institution as well, if somebody is not requiring oxygen, then we are symptomatic. If someone requires oxygen, whether it's 2 liters or 4 liters with risk factors, now remember risk factors are diabetes, hypertension, older age and all that, then we are giving hydroxychloroquine plus minus zithro. And if somebody is requiring oxygen and he's basically getting worse, then we are evaluating for cytokine blockage, which means by day number 2, if oxygenation is going down, not only we are thinking about proning them even before intubation, but also we are thinking in terms of doing these ferritin and other inflammatory markers in addition to the baseline testings. And baseline testing should include all the panels, bacterial, the rest of the urine, pneumo, and all those things that we rule out in these situations. Thank you.
Thank you, Fawad. So let me go to our 2 attendees who have raised hand. Let me go to Muhammad Naeem first. Go ahead, Muhammad Naeem, introduce yourself and give your question.
Assalamu alaikum. I am Dr. Naeem from Gujranwala, family physician with predominant inclination with psychiatric problems. मेरा ये एक question ये है कि all my colleagues just now they are discussing the intensive care management as well as cases which are dealing with. But in the periphery, we in Pakistan, that is primary healthcare physicians, they are scared and they are limited to their homes, not experiencing like that as in USA or in Europe. How we could motivate these physicians to come out and face the problems and get the experience. Recently, a dermatologist in Pakistan, he got COVID-19 and he last night expired. A dermatologist, although has very simple cases of skin, how does he got it and then he got expired? Please, I want to ask how we can, because we are deficient very much about the PPEs and we have no source, even in the government, they are manipulating or they are discussing their own problems, but they are not coming towards the primary healthcare physician and they are limiting stay home, stay safe, just nothing else.
Okay. Yes, that's a very pertinent question. Dr. Mahmood Alam, how to motivate, I think we even in US had a delay from government to public taking it lightly. So what are the lessons learned for Pakistan who may be taking, I hope that it doesn't come to this level in Pakistan, but still, I mean, why to take it lightly?
Yeah. First of all, thank you for bringing that question. In fact, in Pakistan, where only 53 deaths are reported so far, 2 of the physicians have died. And one he mentioned about, he was Abdul Qadir Sumro. He was dermatologist, but he was in hospital administrative positions as well. So it is easy to understand. That brings to the whole point Dr. Muhammad brought up, that we, the healthcare providers, no matter which specialty we are, we go to the hospital, we get exposed to the environment. Okay, doorknob can have a coronavirus there. Okay, the bathroom toilet we use and the knob we turn on and off can have the virus. You wash the hand for 20 seconds, but the end again when you close the knob, you didn't again use something. Okay, there is always a break in the whole cycle of preventing acquiring the virus. And in countries like Pakistan, it is even harder to achieve that kind of sterility and the protectiveness. So my comment is that all of us, even in the United States, there is a multidisciplinary approach to prevent the spread of infection in healthcare providers, whether it is Pakistan or the US. We must sit down with the administration, make sure that ER is involved, infection control is involved, ID is involved, and we have the most robust mechanism and the development of a culture in an institution who looks after each other to avoid that spread. These instances will happen, unfortunately, and I think this virus spread is going to change the way we protect ourselves while working for good. You know, we have been practicing medicine to prevent the spread of highly resistant bacteria like Klebsiella from one patient to the other, but that is very limited. Now we expose ourselves to that, and we can carry it on much faster than the other old known bacteria. So I think it is a wake-up call. Thank you.
Okay, let me ask Dr. Sajid, I'll come back to you. I think Fivzia Herekar from Karachi would also like to add to this or answer. Fivzia, go ahead. Dr. Herekar? Okay, so, all right, Dr. Sajid, you can add to that question.
Yes, thank you, Shahid. Dr. Naeem Saab, I want to address to you that you are right, that, you know, out of 52 deaths in Pakistan, two physicians out of 52 will create a, you know, sense of fear among the physician community, and
Hello.
they might be.
Yeah, I'm here.
Hello.
Dr. Muhammad Ali.
1 minute, sorry. Dr. Sajid, just hold on a minute. I think 3 people are speaking at the same time. Okay, let me, Fivzia.
Yeah, I'm here.
Go ahead. Go ahead.
Yeah, I'm sorry I came in late and I think I missed a very good session in the beginning, but a lot of points I wanted to add, especially for Dr. Abdul Qadir. Unfortunately, he died at Indus Hospital, and unfortunately more is that just 1 week prior to his illness and while he developed his symptoms, he was doing his dermatology clinics. So the issue is that we do have a serious shortage of PPEs, and for big institutes, yes, we may somehow be able to acquire these, but you have to understand the structure of Pakistan. I mean, the way the primary physicians have a penetration into areas, and they don't have an access to what policies and procedures and things are going on. So we have been really asking. It is so alarming to see that the way our case definition has been changing. I mean, before it was just for travel history, then it came in for ijtemas, and we had a pool of people who had come in from Raiwan, and then now it has come down to people, and we are seeing people who've been still going to the mosques in congregations despite the government have taken steps. So we're taking in those pools. Similarly, what we are now fearing is that these people, before coming to big institutes and very small public sector hospitals public and private sector hospitals are offering COVID care. So these people who are poor are going to family physicians, they are going to general physicians, but they need to understand that their health is important for them as well. These general physicians, practitioners have been nebulizing these patients, they have not been taking proper care, whereas when we have, there's a very good way of screening these patients with case definitions before you see them. And the minimal requirement that we had installed for our OPDs initially when we closed them was to have a surgical mask and a shield if we think that the patient is symptomatic. So, and we've observed from studies that have gone on that healthcare workers have acquired the infections through the inoculation through the eye mucosa. So I think it is very important to understand, if you don't have access to PPEs, please do not do your clinical OPDs right now. Please refer them to the hospitals that are offering this service. Second thing is that if you have the capacity to start telemedicine, do that. And so we have gone on to telemedicine. We are contacting our patient pools ourselves. So it's very important to keep, to understand the factor that, you want to help out people, but you need to keep yourself and your family members safe as well.
Right. Okay. So from the same hospital, I think Samreen Sarfaraz also would like to add. So Samreen, go ahead for 1 minute.
Okay. The thing is, I would just like to add one thing. The thing is, we have to emphasize on screening at every portal of entry of a hospital. And for every general practitioner who's sitting there, he should ask certain very easy screening questions and have a high index of suspicion for every patient who comes on in the clinic, and practice basic protective measures like wearing a surgical mask and hand hygiene. I mean, it's very easy to do this. And we have implemented this at the Endos Hospital. We have got screening desks at every point of entry, and everyone gets screened, whether it's as a healthcare worker or it's the patient or the attendant, because you can have it from anyone. There have been cases in Pakistan of healthcare workers acquiring it from their colleagues in the duty rooms. So you can have it from anywhere because it's in the community now. So it's not alarming that that a dermatologist had it. We have had patients coming in from Raiwan who went to general practitioners 3 or 4 times before they landed up in hospital with COVID-19, and they were just prescribed antibiotics. So it's just because doctors in Pakistan are still not getting careful on how to deal with a potentially infected patient.
Okay, Sajid, you wanted to add something, then I'll go. I have a lot of raised hands, so we'll be quick. Everybody, please be brief so that we can get to all of it.
Okay, yes, I think both Fivzia and Samreen addressed this thing, but the concern with Dr. Muhammad Naeem earlier expressed that that's at a small town level. So I think Dr. Naeem, I would just suggest that if anything happens in a small town, so because they have less facilities, so refer them to big towns and bigger centers like Indus or Shifa, or because I'm assuming that they have better facilities compared to general physicians. And of course, what Samreen and Fivzia earlier mentioned, that we have to be careful. Just because we are healthy and asymptomatic right now doesn't mean that we are safe. I mean, in my hospital, we are also, we are sitting on a ticking bomb because, the ICU is full of but I wash and use sanitizer like multiple times during the day. During the care area, we wear masks all the time, and of course, because those people who have beard, they cannot have N95 properly fitted, so they have to use. So I mean, we have that's a separate discussion for protective equipment, but the brief point is that we have to be extra careful and educate your patients also regarding that. Thank you.
I think we will have a topic. I think there are a lot of questions, and that led me to believe that we should ask one of our speakers to give a talk on the protective gear and the protection of healthcare worker, how they can do that. That would be an interesting talk. So let me move on and get to Farhan Qadeer. Please go ahead, Farhan.
Assalamu alaikum. So I only have one question, and from a renal perspective, we're seeing a lot of patients coming up with renal failure, and there is some concern that it's also because of some microthrombi versus ATN versus AKI because of AIN, and the renal function is stable, and the next day they just crash, and people started using CRT, and we're having a lot of concerns about filter clotting, and people are trying to fix the filter clotting, which also tells me that these patients are actually hypercoagulable. So my whole perspective is that there are a lot of also patients who actually have very good compliance, even when they get intubated. So I personally believe that these are the kind of the patient where the heparin should be started, or Lovenox should be started, or some kind of anticoagulation. Though I know with the AKI it's going to be hard to start Lovenox, and even in ICU it's hard to start Lovenox. And the reason I'm talking about it because the paper showed with the Lovenox, and I'm not really sure whether Lovenox is a good option in the ICU setting. And the second question, which a lot of people ask me from Pakistan, and I'm just going to stop right here, is about the use of zinc, vitamin C, vitamin D, and use of those stuff as a prophylactic measure, which I don't have a good answer, but I never told them not to because I don't think it's going to hurt. Thank you.
Thank you, Farhan.
Shahid, I know that we are running short of time, but because this was addressed, so I want to comment on that. I just received a paper on this thing, and even though in ICU patients, we are always reluctant to start Lovenox because of its renal clearance and renal. But the thing is that this option, this article that I got is evaluation of the role of rivaroxaban, which is Xarelto, in hospitalized patients with COVID-19 infection. So they are, what hierarchy they said at, that they are recommending to start Xarelto Xarelto or Lovenox as first, followed by unfractionated heparin. So and if you have some concern that your patients have renal insufficiency, then ask your pharmacist, or you can yourself renally adjust the dose. But that's what they are recommending, and I think most of my colleagues are also doing that. So just want to add that comment.
Thank you. So let me get to two other raised hands. Muhammad Azeem Imran, please introduce yourself and give your question. Imran? Oh no, so that is, okay, so then let me go.
Can you hear me? Can you hear me?
Yes, Azeem, go ahead.
This is Dr. Azeem from Social Security Hospital, working as family physician. I would like to add to Dr. Naeem a concern about the health workers. I had a note which the government of India in March 28, circular was on the web. They started SCQ as a prophylaxis, and the dose they mentioned SCQ 200 milligram, 2 tablets BD for after meals on day 1, and then two tablets once weekly for 7 weeks after meals. would you like to recommend these guidelines for all the health workers coming working in primary care facilities? Any comment from the panelists? Thank you.
Who wants to take it, panelist or speaker?
Okay, yeah, let me add my comment, and then I will love to hear from Fawad and Majid also. I also went through this Government of India guideline that they are recommending as a prophylactic dose, but then the Health Department of Pakistan, I think they were, I think I'm forgetting the name, Dr. Javed Akram. He mentioned that they are not recommending, and he gave a very nice rationale, because even in United States and CDC or our hospital advisories are not recommending this medication as a prophylactic use because of its potential side effect as QT prolongation and porphyria and seizure problem. So the risk and benefit ratio for hydroxychloroquine for prophylactic use is high. I mean, the risk is more and benefit is low. So that's why, as of now, to the best of my knowledge, we are not recommending it for prophylactic use. But I want to hear from Majid and Fawad if they can.
Majid or Fawad?
As I think this is Fawad. I completely agree, and I think it was summarized before. They are still considered as investigational for COVID. Now, mechanism of action, Majid did mention that there is some liposomal activity and there is some, evidence or being worked up, or the real evidence will come when their head-to-head trial gets published. So there is absolutely no reason to start prophylactically from any recommendations. People may still do it, and the biggest issue is again QT prolongation. So I totally agree. There is no evidence and no recommendations from any society to use prophylactically. Treatment-wise, again, there is no recommendation to start, convincing recommendation to start in patients who do not even need oxygen therapy. So the recommendations are coming only for patients who are on oxygen or they're getting worse to start hydroxychloroquine with or without Zithro. So that automatically means that we do not or we should not use these medications prophylactically for both the reasons. They're not going to be available for sicker patients who need it. Secondly, there is no proven efficacy as a prophylaxis. Thank you.
I would quickly say, I completely agree with all of those things, so I won't rehash them. And if you want to focus on what, the general practitioners in Pakistan should be doing, and for that matter, everybody, it's the basic aspects of PPE. I am posting a link to a really good article that looks at how Singapore and Hong Kong have prevented their healthcare workers from falling sick. And the answer is not an N95 mask. The answer is simple things like having the chairs in the waiting room spaced 6 feet apart, wearing a surgical regular mask, making sure you're disinfecting things in between different patient encounters and such. But this article nicely lays out what to do and what not to waste resources on.
Thank you. Anything, Dr. Alim, on it, or we should go to the next questions? We are over time, but let me get to these 2-3 questions. These are mostly on therapeutics, so let me combine them if I can. Obviously, again, comes the role of prednisolone. Then is it ivermectin, that role? And then how much time does it take for the IL-6 level and CRP and LDH to come down after you give tocilizumab? That is another therapeutic question. And then, of course, the convalescence plasma therapy. So, so that's why I combined them. If we can take them together.
Okay. So this is Fawad, Shahid bhai. I can start from the last. Convalescent plasma. There is a paper published with 5 patients' experience in NEJM on 27th March that showed in the severely ARDS patients. Again, very small. You apply it as you wish, but there was significant benefit in those 5 patients in which they gave convalescent plasma, and the PF ratio, PaO2 by FaO2 ratio was below 250 in those patients. So yeah, if it is available, I think again, head-to-head trial will decide, but the first trial that is published of 5 patients from Wuhan did show benefit of convalescent. That's number one. The other question about inflammatory markers, again, IL-6 availability is not that huge, but you basically, the most common experience that has been seen with the TOSI and in our center as well, there is significant improvement in ARDS right away, within a day, within 6 to 8 hours in those patients. And the disease gets worsens anywhere from 7 to 10 days when their inflammatory markers, including interleukin, ferritin, are really high. And then it's just, I personally don't know exactly how many days. I don't think so there is any literature evidence that it's 3 days, 4 days, but they start gradually going down and you see recovery. There is a second wave as well. They sometimes get worse again, despite TOSI. So that's another factor. What was the third question, Shahid bhai? So I can quickly go over.
I think so did you talk about tocilizumab?
Yes, and then convalescent serum, and there was
ivermectin. Any experience on that?
No, I don't have that.
Or methylprednisolone?
Yes. So methylprednisolone, I can definitely answer. So CDC and WHO has recommended against. So whenever we try steroids in ARDS, whether COVID or non-COVID, we have to balance between will that lead, the immunosuppression with steroid will lead to superimposed widespread infection versus benefit of steroids to decrease inflammation that is primarily happening with COVID. Okay, so SCCM, Society of Critical Care Medicine, has given a weak recommendation as opposed to CDC and WHO to use steroids in severe ARDS. Now, Memorial Sloan Kettering is one of the centers where they are using steroids in very severe ARDS with all the parameters we talked about for TOSI. They are using it with steroid in some patients. And there is a trial that is going to be published hopefully within a week, I believe in JAMA. I've reviewed the data that has shown some positive effect of steroid. I cannot speak so much about the trial because it's not yet published, but the expectation is within a week. So again, this is uncharted territory. If TOSI can work, I'm not in favor of steroids in ARDS. There is plenty of data to not use it, but with this disease, again, there is another thing that can be tried, but I think we should wait for the trial to be published before jumping on steroids. One benefit would be TOSI is expensive and not very readily available in many places. Steroids are. So I think if that shows that in severe patients who have cytokine release syndrome, if they can get steroids and get better, rather than using TOSI, that might be helpful. I hope I have explained these questions.
Shahid, I want to add a little bit, if you allow me to.
Sure, go ahead, Sajid.
Yeah, so I agree with Fawad that there is not strong evidence to advocate for steroid use. And the only indication where it can be used, that if you are suspecting or you have reasonable evidence that your patient is going through that cytokine storm, because it has immunosuppressive effect and you want to decrease, as we all know, that cytokine storm is hyperinflammatory response from the host against the viral insult. So even in that case, the Chinese literature is recommending low dose corticosteroid. And when I say low dose, it's like 40 to 80 milligram daily in divided doses for a course of 3 to 6 days. That's what's the and equivalent dose of Decadron 7 to 15 milligram daily. So that has been recommended by Chinese literature. And if I remember correctly, there are guidelines by University of Pennsylvania, UPenn, and I think Mass General. They have also included, but with their recommendation is also weak.
Thank you. I would like to now go to Muhammad Ali Qureshi has raised hand, and I'm not sure if Muhammad Naeem wanted to talk again or I just, it was done. But let's go to Muhammad Ali Qureshi. Please introduce yourself and give your question.
Assalamu alaikum. Are you hearing me?
Ji. Yes. Go ahead, please.
I'm from Hyderabad, Dr. Muhammad Ali Qureshi. My question is that after the expiry of infected with COVID, what happens with the body? Because it presents in the surface area. So somebody says that it's only in the lungs and doesn't happen anything with the dealing persons. But up to which time, up to how much time it is present, the virus is present on the surface area. So let me know about it. Thank you.
Anyone?
Can you repeat the question? I didn't like.
Yes,
ये कहा जाता है और WHO भी यही कहती है कि भाई, मैं रिपीट कर रहा हूँ क्वेश्चन, आवाज आ रही है मेरी आपको?
जी बताइए।
एक्चुअली मैं ये पूछना चाहता हूँ कि WHO भी यही कहती है कि आफ्टर एक्सपायरी ऑफ द इन्फेक्टेड पर्सन देयर इज नो एनी हार्म टू द डीलिंग वन, जो डील करते हैं उसको डेड बॉडी, इसको उसके कोई प्रॉब्लम नहीं है, क्योंकि इस कोविड जो है वो लंग्स में होती है, वायरस जो वहां होता है सर्फ एरिया वगैरह पे नहीं होता, लेकिन टच करने से होता है, तो स्टिल अप टू हाउ मच टाइम इट इज प्रेजेंट इन द सरफेस एरिया बॉडी ऑफ द डेड बॉडी?
Yes. So why
Could
do
you
we
got my
not
question?
give the coffin or
Yes.
janaza and funeral? Is that probably your question? That why they cannot have ghusl and all that?
I can take this.
Go ahead.
Yeah, it's a good question, and there is some information going on social media saying that WHO has said this, but I have not seen the actual WHO document, because that thing which is going on social media, it is written in Urdu. The thing is that there are many different ways in our society, especially in Pakistan, and it depends if you are in a small town, kasba and gaon, या आप किसी बड़े शहर में हैं, तो कि मुर्दे की तदफीन किस तरह से होती है। मेरे भाई, जो सबसे ज़रूरी चीज़ ये है, और अल्लाह ताला का भी ये हमारे लिए यही हुक्म है, कि हम हर सूरत वो लोग जिनको बीमारी नहीं है उनको बचा सकें उन लोगों से जिनको बीमारी हो गई है। अब जो गुजर गए हैं उनके लिए तो वो तो चले गए, लेकिन इस वक्त साइंटिफिकली ये प्रूव करना बड़ा मुश्किल है कि उस फर्द को टच करने से, क्योंकि वो वायरस तो अंदर था, बॉडी पे था या नहीं था, तो उसके क्या असरात होंगे। बट कॉमन सेंस ये है कि देयर इज अ पोटेंशियल फॉर स्प्रेड फ्रॉम दैट डेड बॉडी टू द पर्सन हु विल गिव द गुस्ल। So there are many different options ulama has given. Actually, one of the best talk given is by Dr. I'm blocking his name. 1 hour talk.
Yasir Qadi or
Yasir Qadi. Yasir Qadi on YouTube. You just search it. The fiqh of burial on COVID patient, and he has explained everything. So you can give the ghusl without even touching the body. while the persons who are giving the ghusl should be totally protected by the PPE. Like Sajid Bhai goes to so many rooms every day, live people who can actually sneeze and give virus to any healthcare provider. Okay, but we still do it, right? So if ghusl performing person uses the protective gear, gloves, the gown, the head cover, the goggles or the shield and the mask, and be careful in the spread of the water, probably you can do it. Best practice will be that don't take that body in open white coffin on a charpai to the burial, but again you cannot control it. It's very different. Best thing is to put them in a wooden box and then go to the burial and do that. So I think this question can be posed in the local communities, but potential of spread of infection is there and protective gear is important. Thank
you. Anybody else? I think we are coming to the close of today's session, which really has been very, again, as spirited as the previous one, very interesting discussions, and I'm sure I must have missed some questions, and please forgive me if I did not get to any raised hand or any question. We'll try to get to them. I'll review them. If I left any and Waleed and others can point out, then we can address it tomorrow.
Dr. Shahid, I'll just quickly add, Dr. Herekar is mentioning from Indus Hospital that they do have a nice protocol endorsed by Mufti Taqi Usmani, and it's compliant with Sharia as well as the WHO recommendations, that she's happy to email us. She doesn't know how to share it on Zoom.
Right. And also I would say that Dr. Herekar is going to be our speaker in the coming week. And although her topic is, I think, the experience at Indus Hospital or local Karachi, Pakistan hospital, she can also address that if she would in 5 minutes in her talk, in addition to emailing us. So thank you, Majid. Anybody else? Otherwise, I think I would again thank you, our speaker, Dr. Sajid, our panelists, Dr. Mahmood Alam, Fawad Chaudry, as always, Majid Shafiq, great panelists, Fivzia, and others, and most of all attendees. I would again say that the attendees are as important as the panelists are. It's just our structure that we want to revolve them in 3 panelists each day. So I would again very emphatically request that please give your availability about the dates that you can be a panelist and speaker, and we will put you on the panelist list. We are all in it together. We are all learning from each other. So it's just the structure. Attendees are as important, and we try to get to each one of the attendees. Again, thank you all the panelists and speaker. Till tomorrow. Assalamu alaikum.
Assalamu alaikum. Thank you.
you.
Thank you, Adafis.